Hello dental friends, it's so good to see you again. I have a theory. You can tell exactly how experienced a dentist is by the way they give local anaesthetic. For example, when you see students first giving LA, they're just like, their needles just shuddering like that, they're scared to touch the mucosa, they take an hour to give a cartridge of lidocaine. Then on the other end of the spectrum, when you see a consultant, they just jab it in and give the whole cartridge in like 3 seconds, patient jumps out the chair. The fact of the matter is though, if you can give a painless injection, patients won't really care how experienced you are, they're going to love you. And I think when you're at the start of your career, you've got to take advantage of little things like that. It's very easy to make an injection not so bad. And today I'm going to draw from my own experience, from some evidence that I've looked up and also some other chats I've had with other clinicians about how you can make an injection as comfortable as possible, maybe even painless. Let's get started. Tip number 1, don't neglect the topical. This is pretty obvious, we all know that topical anaesthetic works quite well, but do we all know how to actually use it properly? I would recommend looking at the instructions on the anaesthetic which you use in the practice to see how it's actually used, if you can find it. I tried to find the one online for the one we use and it took forever, but here's how you use them generally. First things first, you need to make sure the mucosa is really dry. So you can use your 3-in-1, you can use a dry cotton pledget just to get that mucosa really dry. That makes it a lot more effective because it doesn't dilute the solution, but also allows it to penetrate a bit better. The second stage is to use a dry pledget or cotton swab to apply that topical to the area you've just dried, and you want to really massage it in so that it encourages the penetration of it into the mucosa. After that, try and keep the area nice and dry if you can until you're ready to actually administer the anaesthetic. How long do you need to wait after applying topical? Well, this depends on which agent you're using. According to the Registered Dental Hygienist website, if you're using something like benzocaine, you need to wait around 30 to 60 seconds, then you're pretty much good to go. If you're using lidocaine, they recommend waiting 3 to 5 minutes before you're ready to use it. I didn't know that. I use lidocaine in practice and I usually wait like a minute. But I think waiting at least 2 minutes would be good to make sure it's effective, otherwise you're kind of wasting your time. And the only way it's going to work is, I guess, through placebo. Number 2 is to know which needle you're using. What I mean is the length of needle that you're using. You can get them in extra short, short and long. In my experience, patients really tend to prefer the extra short ones, so I'll use that whenever I can. If it's a tooth at the back of the mouth, I would use a short one over an extra short just because I need to see what I'm doing, obviously. If you look at the needle itself, it has an arrow on the hub of the needle which indicates which way the bevel is orientated. I found a study online which compared the bevel up versus bevel down method when giving subcutaneous injections. Obviously it's not specifically dental related, but what they found was very interesting. They found that the bevel, when faced upwards away from the mucosa, was a lot more comfortable for patients than when it was faced down. This isn't something that's directly related to dentistry, like I said, but I think it's something interesting to bear in mind and something we can try and adopt into our daily practice to see what kind of a difference it makes. Number 3. Bring the patient to the needle rather than the needle to the patient. This one works quite well for me. I generally hold the lip or retract it with the mirror and put the needle close to the injection site. I then pull the lip into the needle and it's a lot more comfortable than just jabbing it in. If you bring the lip over the bevel until it just disappears and then administer a little bit of anaesthetic, that will numb the area, and as you advance the needle further, the patients won't feel it so much. I went to a talk by a brilliant endodontic specialist who actually says he sometimes gets patients to turn into the needle. I've not been brave enough to try this one. I feel like if I ask the patient to turn slowly towards me, they're just going to whip their head, just jab their face into the needle, they could get hurt. I'm not brave enough to try that one, but it's an interesting thought. Number 4. Try to distract the patient with an adjacent sensation. Distracting the patient obviously takes their mind off the injection, but also if you stimulate their lip, for example pinching it or just rubbing it whilst you're injecting the patient, it follows the gate control theory of pain and it stimulates A beta fibres, which are obviously registering the touch on the lip. That will inhibit the transmission of the pain along C fibres and make the experience a bit less painful for the patient. Like I said, I normally just pinch the lip or rub it a little bit on the outside as I'm injecting, and it kind of distracts the patient from the injection and it generally makes it a little bit painful. For me it works quite well. You see this a lot with palatal infiltrations as well. The clinician normally holds the back of the mirror at the injection site and then slowly puts the needle under the mirror just whilst they're pressing with it, and that will kind of distract them and make it a bit less painful. In my hands this tends to work quite well, so have a go if you don't already and see if it works for you. Another clinician recommended holding the mirror in the area of the greater palatine foramen, so where the 7 and 8 are on the maxillary arch. Holding the mirror there for an extended period of time would temporarily numb the nerve and make a palatal infiltration a lot more comfortable. I've only tried this once, and to be honest it did work, I think, but I think you need to hold it there for quite a while for the nerve to get temporarily numb, so I don't use this one much, but I just thought I'd share it. Number 5, think about the sequence in which you're numbing up the patient. When I'm numbing up a mandibular molar and I'm giving an ID block and a buccal infiltration, I tend to like to go with the ID block first because it's a bit more uncomfortable, and then after the patient is experienced, I say to them, I've got one more to give you, but it's not as uncomfortable as the last one, so don't worry too much. Another thing to consider is what actually happens to the needle after you've given an infiltration. A paper in the International Journal of Oral Maxillofacial Surgery showed scanning electron microscope images of a needle before and after it was used, and as you can see, after it's been used once, it is deformed. It looks kind of like a hook, and as you're pulling it out, it is traumatizing the tissue as you bring it out. If you use that same needle to give another infiltration, it's going to be a bit more painful, I think, than the last one. That's what the evidence seems to suggest anyway. That would make me think, for example, if I'm using the same needle for a buccal and palatal infiltration, maybe I should give the palatal first if the needle would be intact and maybe it would be slightly less painful. A counter argument to give the palatal first is that there's some studies where they've looked at extractions of permanent and deciduous molars in the maxillary arch without giving palatal infiltrations, and those papers that I found show that there was no difference between a buccal articaine infiltration and a buccal palatal lidocaine infiltration. They didn't give any conclusive reason why that was, but because articaine tends to diffuse more, it is likely that it diffused through the bone buccally, palatally, and numb that area enough for a tooth to be taken out. And it stands to reason that if the mucosa is numb enough for a tooth to be extracted, if you give a buccal, wait a little bit and then give a palatal infiltration, because that mucosa is sufficiently numb, it shouldn't be so painful when you give a palatal infiltration, so that's also something to think of. Number 6 is using intrapapillary infiltrations. These I use almost exclusively just for peds, but they tend to work quite well. If you don't know what they are, the idea of them is basically just to give a buccal infiltration first and then numb the lingual or palatal side by going through the buccal mucosa. After giving your buccal infiltration, you go through the papilla buccally, inject small amounts of anaesthetic, and then keep an eye on the palatal or lingual side, so use your mirror for this, and once you see blanching on the palatal or lingual side, that's when you administer 0.5 ml of anaesthetic, and it should numb that part up quite nicely. That way, if you then need to give a lingual or palatal infiltration, the patient shouldn't feel it too much, and like I said, in my experience, these work quite well. If you're anything like me, the first time you do this, you're probably going to go straight through the buccal mucosa, out of the palatal or lingual mucosa, and see the needle kind of just by the tongue or out of the palate. All you need to do is just retract the needle a bit more until you've got that blanching of the lingual or palatal mucosa, and then administer the anaesthetic, and that will get that area really nice and numb. The final point is to inject slowly where you can. I know what you're thinking, oh, that's real groundbreaking, Tam. It's like I didn't know that one already, come on. But just how long should you take? In his book, Handbook of Local Anaesthesia, which I think is in his 7th edition now or something, Dr. Stanley Malamed recommends taking around 60 seconds to administer a cartridge, and he's talking about 1.8 ml cartridges there, so he does recommend going quite slowly. This is good because it makes it more comfortable for the patient, but also it reduces the chance of depositing anaesthetic intravascularly. Finally, there's also evidence to suggest that injecting slowly gives you a better quality of pulpal anaesthesia than injecting quickly. I've mentioned a fair bit of evidence here. I will link it all below in the description so you can check it out if you like. That's it from me, guys. Thank you so much for watching the video. As usual, I had a blast making it. If you have anything that works for you, then please leave it in the comments, because I'm here to learn from you guys just as much as I'd like you guys to learn from me. Don't forget to hit the like button if you enjoyed it, and subscribe if you aren't already. And my next video will be on rubber dams, and I'm pumped for this one. I'll see you soon. Take care.